Right. Assalamu alaikum. And it was an excellent lecture by Professor Tariq Mahmood regarding the safety aspects of radiation in ERCP. Today, we will be discussing the various aspects of ERCP and how the main objects are to make you aware of the indication, the contraindication, the place of ERCP in hepatobiliary medicine. So we'll start off. In fact, I should have modified this. This is the fifth hands-on ERCP course. We've been through the initial bits of the marker. Kidhar hai bhai? Right. So the aims of the course we'll discuss, trainees' background, we've already been through that. Housekeeping is done by Professor Sajda Qureshi. She is the boss. So whatever she says, we have to abide by that. The main course of the main aim of the course is to improve the standard of ERCP performance. This is a very general term and covers all aspects of ERCPs, right? Your expectations, what you should expect from this course. It is not meant to make you a master of ERCP. That ERCP as a procedure is one of the most difficult procedures in gastroenterology. It has got a steep learning curve, and it takes you years to master it. Personally, I've been doing it for over 25 years, and still I feel inadequate at times. So by the end of the course, you should be able to describe the place of ERCP in management of patients with hepatobiliary pancreatic disorders, which is basically the indication for ERCP, when to do it. And also, most important, be aware of the contraindications and complications of ERCP, because whatever you do, it has to be safe. You don't put patients at risk at any time. So the course objectives are to describe the pre and post ERCP, assessment of monitoring used during the procedure, because it is an invasive procedure. Your patient is at risk because of the procedure, because of the sedation that you use, and they have to be properly monitored. You don't just, pass the scope and forget about the patient. The patient, you have to be constantly interactive. Understand the design, control, and function of the duodenoscope, because we'll go through with the models and with the scopes, and demonstration of the basic accessories used in the performance of ERCP. All the cannulas, the guide wires, the sphincterotomes, the stents that you use, we'll try to make you familiar with those, right? The most important aspect of this course is communication. It is an interactive course. We do not encourage just giving lectures out here because most of you will doze off in a few minutes. So please try to ask any question that you feel like asking in the middle of the lecture. Don't worry about it. I'll stop for you. It's good to communicate. It's good to get it out of the system. And it encourages a bit more informality. Betakallufi ke saath, theek hai? So it's not, don't feel intimidated or anything. So here, we are here to teach you, to help you improve your techniques, and it's best done when you are least stressed, right? So in a chill out. So the main thing is, what we will be aiming to do is, especially initially on the models and then on the patient, the safe intubation and extubation of the scope, because that's most important. Once you've intubated the patient, a lot of people get stuck inside the stomach because it's a side viewing scope. It's a different experience. If not used to ERCP scope, the whole experience orientation is different. Because whenever I teach my trainees, I tell them that try thinking about it as driving your car and watching through the side window, not through the front windscreen. So it is different. You have to reorientate yourself. So we teach you structured maneuvers to traverse the stomach and into the pylorus and obtain a short scope position, because once you are in the pylorus, you are opposite the papilla. The most important thing in things are position, position, position. Don't even touch your cannulas unless you got yourself into an optimum position. Otherwise, if you are trying to cannulate from a suboptimal position, it will be impossible. it's difficult enough to get it, get good cannulation from an ideal position. It's still impossible to do it. So try not to mess around, from far. So always get yourself into a good position before you touch any accessories. And we will be discussing with you in good time the different ways of obtaining selective cannulation during the procedure. Dr. Khalid Hassan has got a very good lecture on the difficult cannulation techniques, so it will all come through the course. What we try to do is give to you the different micro sort of teachings in small doses so that it's easy for you to retain. We'll also discuss diathermy as related to sphincterotomy. We will be doing most of that practically, because when you are doing the procedure, if the patient has got stones, we'll be doing sphincterotomy and help you perform sphincterotomy if it's safe. And also at the same time, if the patient has got stones or if they require stents, we'll try and help you carry out those procedures. But remember, in everything, our aim is to help you perform those procedures, but safety comes first, because we are not performing this on a model, it will be on a live patient, and life is precious, right? So that's dedicated to one of my colleagues there who used to run the course in Liverpool with me. First of all, indications. Right, now let's make it a bit interactive. I've put on deliberately emergency, urgent, routine, diagnostic, therapeutic, control, rendezvous procedure. What's an emergency procedure indication for ERCP? Pardon? Right, okay. Right, okay. We normally don't see that, but anyway, that's his emergency, yes. Yes, yeah. Okay, fine. Emergency is acute ascending cholangitis, right? So there's no doubt about that. And ligation of drug should be, well, it shouldn't happen, but yes, that can be an emergency procedure for it. Urgent. Okay, yeah, okay. So urgent, yeah. What else? What is hemophilia? Okay. Right. Right, okay, let's concentrate on one thing. How many hemophilia cases have you seen? Acha. What was wrong with that? Good. It's very rare, hemophilia to see. Now, it's more talked about. So always, whenever you give your answer, talk about things that you've seen are common things. Hemophilia, you've seen one, I probably might have seen one or two, and I've been practicing for over 30 years. So it's not something which is common, right? So always, whenever you are answering an exam, mashallah, you're all professors now, but still talk about, because that is practical medicine you want to practice, right? Okay, so urgent is biliary leak, yeah, possible. Biliary leaks. Yeah, again, patient who are getting severe pain, obstructing, right, okay? Obstructive jaundice, but that is, again, so any severe routine. Yes, that's right, yes. So it's a more, but the main emergency, urgent ones are cases of acute cholangitis, biliary leaks, acute pancreatitis if it's indicated, if the patient's condition is getting worse. So any of those would come under urgent. Stones which are symptomatic, right? Okay. So diagnostic, very rarely ERCP is done as a diagnostic procedure. We do not do ERCP with a diagnostic intent because there are other non-invasive procedures available. So why do you want to subject somebody to a risk of complications by doing an ERCP? So it is totally unjustified. That's why I've deliberately put it in. So I would not do an ERCP for a diagnostic reason. If you want to look for stones, if you want to look for sclerosing cholangitis, the preferred procedure is MRCP. However, sometimes if it is clinically indicated, then you would do it. If the patient has got all the hallmarks of stone disease and your ultrasound scan is negative or even MRCP is negative and you still strongly suspect clinically that he has got biliary stones because of the history of pain, jaundice, then yes, it is justifiable to do a well, it's not, again, it is with therapeutic intent. But first of all, you must do non-invasive procedures.
Also,
So,
we can do in sphincter of body dysfunction.
yes, yeah, I mean that again, you know, but that is therapeutic intent. You don't do ERCP for sphincter of body dysfunction to diagnose it. You diagnose it either on the basis of your clinical and biochemical reasons or by doing manometry studies. You do ERCP to do a sphincterotomy. Okay, so coming back to indications again, choledocholithasis is one of the commonest indications for ERCPs, right? It can cause extrahepatic biliary obstructions, cholangitis, pain, and sometimes when people undergo cholecystectomy laparoscopically, the common bile duct is not explored, or they explore it and find that it's got stones in it, then rather than do an open drainage procedure, because that is a major surgery with more morbidity, longer post-operative stay, most of our surgeons would just close, take the gallbladder out, and ask us to do the ERCP to clear the duct. So those are your indications for ERCP in stone disease. Any CVD stone should basically come out because it will cause obstruction. Right, so stricture disease, yeah.
Transplant patient.
Yes, yeah, post-transplant you will see it usually, but any benign strictures, and benign strictures are, you know, due to those conditions. Right, so sphincter of body dysfunction, both type 1, type 2, you will do ERCP. What are the malignant indications for ERCP? In what malignant conditions would you do ERCP?
C-head of pancreas.
Yeah, okay, so cholangiocarcinoma, C-head of pancreas, what else? Okay, good.
Lesions of the pancreas.
Hmm?
Cystic lesions of the pancreas.
Sorry, just.
Cystic lesions of pancreas.
Cystic lesions of pancreas.
Cystic, oh, sorry, I beg your pardon. Sorry.
And sometimes hepatocellular carcinoma if it is obstructing the main duct.
Okay.
Or
Yes, cholangiocarcinoma.
extrinsic compressions, malignant extrinsic compressions from.
You've done your reading very well. Good. Right.
Biliary fistulas like hiatic cyst communicating with the biliary.
That's not malignant, that's benign.
Benign.
Right. So, malignant biliary obstruction, right? So, it's ampullary carcinoma, pancreatic CA, cholangio, gallbladder CA, extrinsic nodal compression. Extrinsic is especially, you know, other conditions, lymphoma, breast CA, anything which would cause metastasis to the portal area, lymph nodes, and cause compression. Yeah, okay. So that is your thing. Pancreatic disease. Well, one thing I should mention before we go through that is that you people are not going to do ERCPs for pancreatic indication, full stop. It is something which is specialized and should be done by people who are experts, right? So any pancreatic work should be sent to Dr. Sadnyas. That will increase his workload. So acute severe biliary pancreatitis, again, it is benign, but it is a challenging ERCP if you do it, especially in acute cases.
I can say that it's very disappointing for me that people who have attended this course have actually gone after the course. And I've seen the reports where they've attempted the most difficult cases, where we didn't think they were suitable actually to do very simple cases.
Even my regular
do
colleagues.
What Bakar is saying, but for God's sake, at least reach that level.
Yeah.
Just because you want to add up your cases, how can I say no? Patient
Yeah.
फिर मुझे तो बोलेगा मुझे तो कुछ आता ही नहीं, मैं तो बड़ा डॉक्टर हुई नहीं. So that approach will actually lead you to that will
Yes.
eventually lead your name. I've struck those people off. They can never enter my unit. I'll never teach them anything. And I tell my patients they shouldn't have done it, especially if there is disaster they've caused.
Yeah.
So it's a bad thing. I think you need to give yourself time. You need to understand, like you say,
Yeah.
there are limitations, yeah.
You
Not
shouldn't be
everybody
touching
can be
those.
as good as Waqar and Khalid, period, yeah.
In our hospital, I am
Is
the only person who does
everybody-
this.
you know,
And I've got some very good.
Unfortunately, we are not.
Yeah.
Not everybody is is able to do everything, very well. So if you're not, then just limit yourself. That's the point.
Yeah.
Anyway. Sorry.
It's always very challenging to do ERCP in acute severe biliary pancreatitis. I mean, it can be life-saving, very important, because if the patient is getting worse, first of all, indication for it is also important, because in biliary pancreatitis, if the patient is getting better, everything is settling down, you don't need to do an ERCP. Let it settle down. You can do an elective ERCP a few weeks later when everything's settled. However, there are conditions when these patients need an emergency ERCP because the patient is getting worse, the jaundice is getting worse, and they are slipping through. In that case, it should be done only by people who are experts, because the whole of the anatomy in that area is altered. The whole papilla is swollen, the duodenum is swollen, the papilla is twisted in a skewed position, you can't get to it easily. So it's a high-risk procedure. It has to be done by people who are experienced. Even in our hospital, I've got some very skilled ERCP endoscopists, but I'm the only person they usually refer the cases to. So it has to be done by a person who know what they're doing. Recurrent acute pancreatitis, again, that is an indication for doing an ERCP because you are suspecting conditions like microlithiasis or sphincter of Oddi dysfunction or other obscure causes, and I think should be done by people who know what they are doing, because these are difficult indications. Traumatic disruption, again, a job for the expert. Not everyone can do it, and we usually come across these cases, especially in my practice, in patients with road traffic accidents, because they've come up, they end up with pancreatitis quite severe and duct disruption. We usually stent those patients. Quite rewarding procedure, but to be done by experts. Chronic pancreatitis, again, something not for the weak-hearted. It should be done by experts because you end up doing pancreatic duct sphincterotomy, which is comparatively higher risk of causing bleeding and perforation if not done properly. You can remove stones from the pancreatic duct, but again, challenging procedure, stricture dilatation, pseudocyst drainage, because I remember one case I had which was complex strictures in the PD, and I used to call my consultant radiologist colleague to do it with me because he was much better than I was at passing the guide wires through. So you have always get your best skilled people to do it with you. Contraindication, very important. First of all, when there's no indication for it, you don't do it for the hell of it, ke, chale yaar, scope mil gaya, aao isko try karte hain. Never do something like that. Whenever the patient has refused consent, don't try to push him into it, especially if you are in the private sector. Unstable patient. Whatever surgical procedure, a surgeon will not operate on an unstable patient unless, it's an emergency and it's a life and death situation. Similarly for ERCP, you have to be to make sure that your patient is safe to be, operated upon. Perforated viscous, of course, if there's any perforation anywhere, you don't mess around with passing scopes down and putting more air into the peritoneal cavity. Any recent upper GI surgery is a contraindication for ERCP. Operator not trained to the level required in performing ERCPs. Don't do, if you are a bantamweight boxer, you don't go out and fight a heavyweight boxer because he'll knock you out in the first punch. So never do something which is out of your weight range.
May I ask one question from Dr. Khalid?
Yes, sir.
Sir,
Sir.
what is the level required in performing ERCPs? Please elaborate correctly.
What is the level required for performing these ERCPs or basic ERCPs?
Basic ERCPs.
Basic, yes.
Basic ERCPs, you start like you've come to this hands-on course. You will get to know where you stand today, and then it's a comfort level. My simple is, would you be happy to do an ERCP on your mother?
Absolutely not.
Anyone here? Or a daughter? If you're not happy to do it on your father, mother, daughter,
Brother.
yourself, brother, anybody that you care for, then don't do it on your patient. He is also somebody's brother. So that doesn't mean we don't learn. That means you have someone stand with you who's, I have no problems you doing anybody's case as long as there is Vakar is standing next to you. He'll tell you, stop, don't cut, not this way. Let's call it a day. Can't do it. Okay, whatever. So everybody can do ERCP as long as they are learning under supervision. When you start doing independently, ask yourself a question. This is my simple formula. अपने बेटी में नहीं कर सकते, दूसरे की बेटी में मत करो खुदा के लिए. फिर ये नमाजें और ये रोजे और ये सब बकवास. That means you haven't understood. You will be answerable in the eyes of Allah. We have no accountability in this country. लेकिन भाई ऊपर accountability है. अपनी जब कोई खास मरीज होते हैं तो यही बहुत सारे लोग अपने मरीज मेरे पास भेज देते हैं. और जब गरीब आदमी आता है जिसको कोई पूछने वाला नहीं होता उसको खुद कर देते हैं. अगर उसको कॉम्प्लिकेशन हो गई तो हो गई सर. ये तो पार्ट ऑफ द हर एक से होती है, हर एक से नहीं होती. If your failure is 4 or 5 on 10, you should not be doing ERCP. Correct me, sir, if I'm wrong?
Absolutely.
Anybody doing cannulation and not able to do less than 9 out of 10, should he be doing ERCPs? No. Are you at that level? And if you're not, take a step back. And if you've done it enough and you're still not reaching, call it a day, yeah? You might be better in colonoscopy. How many gastroenterologists in US
Very few.
would be doing good ERCPs, Khalid, or would be allowed to do ERCPs percentage-wise?
Very few.
Very
Like,
few.
I would say less than, not even 10%.
I think less than 10%.
people do, ERCP. And it's not, you're not gonna get to that 90% on the first day.
Yeah.
The point is, like, you will eventually get there. That's not, it's not discouraging you from doing a ERCP. In the beginning, everybody needs help. Like, you're not going to be starting to cannulate every person from the day one. You're going to need some help, supervision, call the person. Don't be like, as endoscopists, not as endoscopists, I shouldn't say, even the surgeons, all us, we have this ego which never goes away. मैंने अगर किसी को बुला लिया तो वो क्या कहेगा? But if somebody is better than you think he can help you with that, just ask for that. So that's the point. And people will get there. To that
When I
90%.
said 9 or 10 is when you think you are able to do it yourself. That's the requirement. That's the BMG requirement. So if your centers are doing 500 ERCP but are successful in 60%,
That's not good. That you shouldn't be doing it.
then I'm sorry, you need to go back and think and know what you're doing.
वैसे मैंडेटरी फिगर जो है हमारा यूके में जो ट्रेनीज के लिए होता है बिफोर दे आर अचीव्ड एज कॉम्पिटेंट और एबल टू डू इट इंडिपेंडेंटली, तो वो उसकी हम वो करते हैं, डॉप्स करते हैं, समेशन डॉप. दैट वी ओनली डू आफ्टर 300 प्रोसीजर्स. 300 हाँ, वो मतलब एक मैंडेटरी एक वो है फिगर है जो कि
What
हम
do you
यूज
think
करते हैं.
is the average Pakistani figure for doing independent ERCP?
I don't know. I think from what stories I hear, horror stories, so वो तो 5-10 पे भी करते हैं, लेकिन क्योंकि तारिक महमूद, प्रोफेसर तारिक महमूद,
25 to 30.
प्रोफेसर तारिक महमूद asked me last year कि उससे पहले साल था कि there was a person who we trained in this course. So he asked me कि वकार if such and such person is he or she competent to do it. तो वो बार मुझे मतलब कह रहे हैं कि I want to start doing it independently. I said no way ना. मैंने कहा तो
I'll give you an information. That very person started doing independent.
I know, I heard about it, but that is, you know, तो तारिक महमूद को तो खैर तारिक महमूद is a very responsible person, so he wouldn't allow it in his unit.
Yeah, I know.
लेकिन I know she अच्छा तो that person started practicing. We all know about that. So
So it will be slightly digressing, but in the private setup, hospital is only interested in you bringing the patient.
yeah.
So actually,
Yeah, I know of someone who was good at not doing 10 ERCP.
हाँ ये that's
professor in this city who wanted to do an ERCP on a pregnant lady. In the private setup, no question asked, उस मरीज की किस्मत थी अल्लाह ने क्या करना था कि I found out. And I told the private center, if this patient is done, it will be my last case today.
अच्छा.
And so they said, no, 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 this case will not be done. So eventually it wasn't done. But how many slip कर ये तो इत्तेफाक से पता चल गया. But the point here is that हर चीज़ में तो हम West को follow करते हैं ना. Guidelines आप उनकी लेते हो, exam आप उनका follow करते हो. When it comes to techniques, when it comes to procedure, nobody is discouraging you. We're not saying that he is specialist and I am हमको ऊपर से उतरे. No, it's just a question of proper training, giving time and understanding that this is a lethal procedure. People die of this procedure. People die of colonoscopy as well in the city a lot, but that's besides the point.
Which is
The point is,
unacceptable.
if you do it properly, then you will save lives. That's what you are the doctor for. It's not about ego. बहुत दफ़ा आपकी ईगो, मैं बुला लूँगा तो मरीज़ क्या बोलेगा, मैंने अपना पेशेंट किसी के पास भेज दिया, हैदराबाद का यहाँ पे बच्चे बैठे हुए. I have regular referrals from Amir Wali. आप आमिर के साथ हैं? I have regular referrals from Sadiq. Does it make any difference to them?
उनकी इज्जत बढ़ जाती है.
In fact, their patients, when they come to me, I said, you know, go back to them. I don't need to see you. I've done what I had to do, but you don't have to come back for stent exchange. And I tell them, it's just because I'm older than them. Nothing else. And they are very safe people. They've got their lines, so they have developed. You know, and they are becoming good and good every time. You know, अब जब cases उनके आते हैं तो अब मुझे पता चलता है कि मुझे भी थोड़ा सा time लगता है. If the problem is, like I was discussing with Khalid, आपने एक patient को नहीं किया और आपने डॉक्टर वकार के पास भेजा और उन्होंने 2.5 मिनट में कर दिया. There is a problem, my dear. आपसे एक केस नहीं हुआ और मुझे भी आधा घंटा लगा और फिर मुझे कट करना पड़ा, ये करना पड़ा, then fine. But if you do something and you say, oh very difficult, नहीं हुआ मरीज को, and वो मरीज इनके पास आया और उन्होंने 3 मिनट में कर दिया, वो कहेगा भाई वो क्या कर रहे थे. अब आपकी रेपुटेशन तो बैठ गई. अब क्या हुआ आपकी रेपुटेशन? अब उसने जाके हर एक को बताना है. So you have to think that way. Sorry.
Risk of ERCP. Risk to the staff, which we had a very good lecture from Professor Tariq Mahmood. Main risk is radiation safety, and I think it is very important to be aware of that for your own personal good. इसमें आप patient का नहीं देख रहे, आप अपना and your staff, because your staff is your responsibility. You are the captain of the ship. You have to be responsible for their safety as well. ये नहीं कि खुद lead aprons पहन लिया और उनको ऐसे ही नंगा फिरा रहे हैं. So that should not happen. Normally, we all wear dosimeters, we all have thyroid shields, but in our unit, I'm sure Khalid also has that, we've got lead glass between the shield, the screen, the thing, the equipment, the fluoroscopy, and the patient and ourselves, and another lead sort of curtain under it, ताकि बिल्कुल minimize हो जाए. So, and normally we don't allow pregnant staff members inside the ERCP suite. Technical failure can occur, especially a scope can break down in the middle of your procedure and everything goes dark. So in that case, the best thing to do is to come out. Clinical failures can occur due to technical reasons, failed cannulation or anything. Unplanned adverse events are complications. So what are the possible complications you can get in the ERCP?
No. At this stage of your life, you don't have to say perforation. I need a percentage. So what is the risk? Perforation, what's the percentage? How many patients is an acceptable perforation risk in a center?
अब डॉक्टर साहब एक और बात, हाँ डॉक्टर साहब एक बात, आपने हीमोफीलिया भी कहा था. आप डॉक्टर साहब एक काम करें, रेयर चीज़ों के पीछे ना आ जाएं. Think of common things जो कि ERCP में कितने लोग ERCP में आपके परफोरेशन करते हैं. हाँ जी, that's always talk sensibly. देखिए आप हीमोफीलिया से जब स्टार्ट करते हैं ना, हीमोफीलिया से मैंने 2-3 केसेस मैंने भी नहीं देखे. तो always start with common things. Pancreatitis, simple.
Okay, let's perforation में 1% किसी ने कहा था.
हाँ.
किसी ने कहा 0.1%. वही point
हाँ
one.
हाँ ठीक है वहाँ हाँ
So
सही है.
yeah, you know, that's looking more realistic. 1%
Is you shouldn't
got
be
a
doing
major
it.
issue,
You
my
got
dear.
a
That's 10 times
big
higher
problem.
than what is expected.
20
What
times.
about pancreatitis? What is the percentage?
3 to 5%.
Do you monitor your pancreatitis in the units that you work?
Yeah.
You are?
No, sir.
कहाँ monitor करते हैं यार?
अगर patient को सर overnight stay करवाते हैं, patient को मॉनिटर 6 आवर तक allow करते हैं.
So what's the risk of pancreatitis in your practice?
So when I'm working in the academic hospital, around 5 to 8% patient get back.
So
When
we
I'm working
just
in academic hospital,
okay 5 to 8% Liagat National Hospital. So the range of pancreatitis is pretty variable depending on centers and the volume you do. So if I'm not wrong, anywhere around 2.5 to 3%
That's
would be on the lower side, and it has been reported in the literature up to 18%.
Yeah.
But obviously, if a
Which is
center
very-
is achieving 3% and the other center is having 5 times, there is a problem.
A serious problem.
Okay, there is a problem. So I think anyway 3 to 5% is acceptable.
We'll give you the figures, don't worry.
secondly, acute cholecystitis.
We have published our thing. We did a prospective 500 consecutive cases to check for pancreatitis, and our pancreatitis risk was 2.9%. Okay, and that out of 500 of the 2.9%, except for one, all of them were what we call mild pancreatitis, nothing serious, no death. So that's consecutive, and we followed those patients with
No
amyloid-
mortality.
not in the 500 series due to pancreatitis.
Right?
And
So
ICU admission.
basically complication जो है तो वो
Only
that
one
is
patient with prolonged admission of 5 days, so that's why it becomes severe pancreatitis, not because of severity. वो admission से है ना वो
हाँ,
Markman criteria.
we'll tell
Most
you.
of them were discharged next day.
ठीक. So basically complication जो है that's an adverse event related to the procedure and requiring treatment in hospital. So that's the
Sorry,
definition.
Waqar, there's one more
जी.
thing that happens very commonly with pancreatitis. Cholangitis. So what is the risk of cholangitis in our practice? आप लोगों को कुछ idea? It's higher in Pakistan. It's much lower there.
We hardly ever see it.
It's still not that common, but it's higher in Pakistan for 2 reasons. One, because our patients come very late. I think by the time they come, so एक तो ये भी हो जाता है. दूसरा, I think we reuse accessories, so that is another thing. And our cleaning of equipment is not as stringent as it is in the West, and especially in the ERCP scope, the cleaning becomes very important. So those are the reasons our cholangitis is higher, but not so high. I can't put a figure on that because it's difficult. Bleeding. What's the risk of bleeding in ERCP? 0.1?
Sir, minor losing तो जो है वो तो
No, I'm talking about minor injury to नहीं count. Bleeding that is significant. Significant bleeding post ERCP 0.1
Yes, sir.
should be accepted.
Yeah. It's very rare.
So 1 in 1,000 means once a year
Ah.
in our unit.
In fact, in the total 20 years in this job, I've had only 3 cases of really severe bleeding, जिसमें multiple transfusions use किए हैं. Eventually, we had to use embolization in one of them. The other one stopped spontaneously, और तीसरा इतना it wasn't so bad. So severe जो हैं, so they are very rare. Right. Severity criteria जो है कि how bad your complication is. अगर mild, the way we arbitrarily classify them is if it's only a 1 to 3 night hospital stay, then it's considered as mild. If it is 4 to 9 nights in hospital, that's deemed as moderate. And anything above 10 nights in hospital or admission to ITU or requiring surgery is deemed as severe complication, and fatal is all you know what fatal is. Sorry. Overall complication rate अगर random वो देखा जाए तो उसका ERCP का was 5 to 10%, considering all cause complication. 30-day mortality from various series was reported as 0.2 to 2.2%. That is all cause complication, ठीक? And it is worrying because there is quite a bit of variation there. तो वही बात होती है यूनिट की और उसकी. And this was done on an audit conducted quite some time ago in UK. फिर जब all cause mortality तो 0.2 to 2.2 थी, लेकिन when they coned it down to procedure related mortality, the mortality was 0.04%, which is 4 in हाँ नहीं 4 in 10,000, 4 in 10,000, which is 2.5. हाँ, तो 4 in 10,000 is mortality related to procedures था, तो which is acceptable क्योंकि इतना वो होता है ऐसे. तो there was no relation between the difficulty of the procedure and the mortality or severity of complications. क्योंकि बाज़ वक्त it can even happen in very good hands, but then again, if it keeps happening very often, then you have to think कि क्यों हो रहा है.
Yeah, I think the severity, the point he's making is, I think it's important. The severity of pancreatitis जो है आपका वो आपके हाथ में नहीं होता. It's not, you've manipulated the ampulla and the patient has pancreatitis. Whether that will become severe or not, it doesn't make any difference कि मैं कर रहा हूँ या आप कर रहे हैं. जो pancreatitis हो गया, फिर patient में severe हो जाएगा, कुछ में नहीं होगा. It's not nothing to do with it.
Exactly.
But overall pancreatitis का risk obviously is dependent on your skills and your ability to manipulate.
Again, आप ये यहाँ पे क्लासिफिकेशन दी है काफ़ी. इट्स अ गुड वे टू सेपरेट कि आप किस लेवल पे ऑपरेट करें. तो ये है ERCP डिग्री ऑफ डिफ़िकल्टी. ये वो लीग टेबल है ना, जैसे फुटबॉल में होता है प्रीमियर लीग, फर्स्ट डिवीज़न, सेकंड डिवीज़न. तो उसी तरह ग्रेड 1 जो है तो डीप कैनुलेशन, अगर इफ़ यू आर एबल टू डू अचीव डीप कैनुलेशन, बायोप्सी और साइटोलॉजी एंड बिलियरी स्फिंक्टरोटमी, stones less than 10 millimeter, stents for leakage are low tumors. Simple procedures, which is something which all of you should be aspiring to. Because that is, if you get up to this level, you have achieved your initial objective. So this is what you want to do initially. उसके बाद आता है grade 2 or advanced operators, which is bill rot 2 में अगर ERCP करना है, which is always a challenging procedure. We do it, but it is, even now I find it challenging. Minor papilla cannulation again is a challenging procedure. Stones greater than 10 millimeter can be difficult. Higher tumor stent placement again should be done by experienced endoscopists because it is difficult. Similarly, grade 3 is for the real experts. Those cases you should not even think of doing, and they are high risk procedure. Patients who have had sphincter manometry, who need sphincter manometry Whipples, who are post-Whipple, who are post-Roux-en-Y, intraductal endoscopy, they are all for the experts, advanced procedure. So forget about this one, and also for the time being this one. Think of that one, basically.
Sir, what about sphincteroplasty?
Sphincteroplasty, again, it's an advanced procedure. I wouldn't recommend you people doing it. Because you are disrupting the sphincter, it is a major procedure, or it can cause major complications like bleeding. You can tear the duct, and you can cause pancreatitis risk is very high in sphincteroplasty. I wouldn't do it.
It says grade 2 advanced stones more than 10 mm. So 10 mm से कम में तो आप कभी sphincteroplasty करते ही नहीं हो. So you are already in advanced grade anyway. So obviously that's important.
So, in fact, UK में sphincteroplasty was only started a few years ago. It wasn't licensed to be done. You can't stress the importance of operator-related issues. If you are not qualified, are not skilled enough to perform a procedure, don't do it. Send it to somewhere else. Again, selection of your patients, very important, because if your patient has got severe COPD, is a post-myocardial infarction patient, has got heart valve replacement, is got other risk factors, he might be suffering with acute cholangitis and in septicemic shock, so all those are important and would add on to your complication issues. Sometimes we do ERCP on fairly frail elderly patients because that may be the only palliative procedure that you can offer them, but you have to be very selective because you still, it is going to help them, but you do not want to be the cause of their death. So always select your patients carefully. Whenever you do anything and carry out treatment, your risk of complication goes up. If you carry out a diagnostic colonoscopy, your risk of perforation is 0. If you carry out a therapeutic colonoscopy involving large polypectomies or flat adenoma resection, your risk increases exponentially. Similarly, in ERCP, the higher the risk procedure that you perform, the higher the risk of your complication. Again, I would stress that doing ERCP is not something that you do as a diagnostic procedure, because it's, even if you don't carry out any therapeutic procedure, ERCP still carries the risk of pancreatitis in diagnostic procedure and even perforation if you are not careful. And I've seen people perforate, and it's very difficult to justify a complication when the procedure was not indicated. So always think about, how it's performed. If you are carrying out sphincterotomy, the difference in carrying out, the difference in complication is different whether you do a biliary sphincterotomy, whether you do a pancreatic duct sphincterotomy, whether you do a pre-cut or whether you do a repeat. Because pancreatic sphincterotomy carries a higher risk of bleeding and perforation if you are not careful. Pre-cut is always difficult. It is always more risk-prone, bleeding-prone, and more perforation-prone. And normally, I would not recommend that any of you should even attempt pre-cuts because you do not know exactly where to place your cut. If you do deep cannulation and you do a proper sphincterotomy, you are protected by the line of cut because the cannula is already in this cannula is already in the duct, and it tells you where to go for your line of cut. But in pre-cut, you have to make that judgment. And with your experience, I would not recommend. A repeat sphincterotomy in a patient who has had a sphincterotomy in the past, it's because it might have, stenosed off due to scar tissue. Repeat sphincterotomy is always high risk because of more risk of bleeding. Balloon sphincteroplasty is always a high risk, should not be done by the inexperienced because there's high risk of causing bleeding, high risk of causing disruption to the duct, high risk of causing pancreatitis. So you should not do it. Normally, we recommend a small sphincterotomy before the balloon sphincteroplasty because just like an episiotomy in labor. Papillectomy, stenting, pseudocyst drainage are all advanced procedure and should not be considered by this group at least. Now, in UK, about 20 years ago, endoscopic procedure was sort of quite uncontrolled. The regulations were fairly sort of loose, and people could do ERCPs and colonoscopies fairly unregulated, not to the extent it's done here, but still. However, one of the good things that's always done in those countries is that they have the process of audit. And audit is something which really governs our clinical practice. We are all audited every year. The figures are made public, and now it's a mandatory requirement that we should have, at the end of the year, our audit figures published. So BSG, which is British Society of Gastroenterology, carried out a very big ERCP audit, just like they did audit on colonoscopy and other procedures. And in that, they analyzed, audited about over 5,000 ERCPs in over 4,500 patients, covering a period of 6 months. It was done prospectively in 66 units. And in fact, the main age for the patient was about 65 years. which is much lower than our general practice because we do a lot more elderly patients than 65. So if you do a more elderly population, the risk of your complications is far higher. So they did a very elegant study that they, the follow-up data was, they were able to capture it in, for 24 hours in almost 97% and for 1 month in 92%. So it's quite a robust data we got out of that. And the overall complication rate was pretty impressive. 5.1% risk of procedure-related complications, which is reasonably high. So that's why it should not be something done for diagnostic purposes. Pancreatitis was fairly average for what we normally see around the procedure. Cholangitis, all those complication risks were highlighted by this big audit study, and we all got back to the drawing boards and started thinking. Pancreatitis is by far one of the commonest complications that you would come across, and Khalid Hassan has got a very good lecture on that, so I wouldn't dwell too much on it. But it's the main presentation, of course, is immediately post-procedure is the pain you get from pancreatitis, and it becomes quite evident very soon after the procedure. So normally, after performing ERCPs, if you check anyone's amylase level, they would be high anyway. So you shouldn't get too excited by hyperamylasemia, but if it is more than 3 times the normal level, and it is associated with pain, then obviously that is pancreatitis. Can occur in 2 to 9% cases. Obviously, average is about 2%. 9, you are doing something wrong. Typical profile of a patient who is going to get pancreatitis is your young female, previous pancreatitis, or sphincter of Oddi dysfunction. Sometimes the one who rarely needs it. So always be careful in this type of patient. And it is more common if you keep on getting repeated cannulation into your pancreatic duct and keep injecting contrast into it, or after balloon sphincteroplasty. So, right? By far, the majority of your cases of pancreatitis post-ERCP are fairly mild, and they would get better without any active intervention, usually in a couple of days. And that's the sort of a picture you see of the pancreas, a bit of a mess, causing pressure on the duodenum and the stomach. This is the typical profile of the patient you would get with pancreatitis. And you have to be careful about all those. As I said, Khalid Hassan gave a very good lecture on post-op ERCP pancreatitis, so I wouldn't dwell too much on it. Have you still got that? No?
Yeah, we can do it.
Yeah. Yeah, because last time you did very well, so I thought. But anyway, I'll just briefly mention it. So prevention of pancreatitis. Avoid ERCP in high-risk situations, just like I mentioned. Mechanical factors is whenever you try to do cannulation, we nowadays do wire cannulations first, rather than keep on going with cannulas and injecting contrast. So if you see the wire going into the wrong duct, just withdraw. Always use minimal amount of contrast needed. And we use isosmotic contrast, not ionic forms, which less liable to induce pancreatitis. Pharmacoprophylaxis usually give them NSAID suppositories post-procedure. Common one we use is diclofenac. Some people use indomethacin. They are both equally effective. And pancreatic stenting. If you've been probing the pancreatic duct on multiple occasions, then always a good idea to put a pancreatic duct and do a pancreatic duct sphincterotomy.
Minimum attempt, like 3?
Pardon?
Minimum attempt to pancreatic duct to put the stent?
Oh,
Minimum, there is no minimum. Normally, it depends.
So you're saying if you go into the pancreatic duct 3 times,
You put.
you should put a stent in?
I think I would strongly discourage you to do that because you are adding on another complication then.
What he's
Yes,
trying to
I
ask
know,
is
yes, yeah.
that if you're actually, when you're trying to cannulate the
Yes,
artery,
yeah,
and you're
yes,
getting
I
into
know.
pancreatic duct, how many times do you get into the pancreatic duct before you say, okay, now, if, I have to place a stent.
I think it's very difficult to answer that, because what I'll tell you, I normally do in my own practices, if I find that it has had quite a bit of prodding, then I would put a stent in. Even if I've got several times and it's a very gentle cannulation or gentle wire, I wouldn't bother. Because when you are doing a pancreatic duct stent or a pancreatic duct sphincterotomy, you are adding on another procedure with complication. So always be careful of that. Some people find it an excuse. I was talking to a colleague, and he does it in almost every case. He's putting pancreatic duct stents and sphincterotomy, which I think is wrong, because all these should be your clinical judgment, and it should be.
Doing pancreatic sphincterotomies to put pancreatic stents to prevent pancreatitis?
Just in case he goes into the pancreatic duct. I won't mention his name because you know him, but whenever he does that, he said, "Oh, don't you do that?" I said, "No, I never do that." So even one or two, passes into the pancreatic duct, he would put and he would do a sphincterotomy as well, which I think is wrong, because you are doing a high-risk procedure again.
Wire-guided pancreatic duct ablation, you don't need pancreatic.
Normally, I feel that I've not caused any trauma, because first of all, your cannulation should be very gentle. Wire guided may be बहुत gentle, extremely, क्योंकि it's a very soft procedure. It's just like playing golf. When you do the swing, you don't hit the ball first by doing putting all your power into it. It's your rhythm, it's your touch which matters, not how much power you use or how rough you are. So if it's we all get 1 or 2, 3 attempts, and then by the time, if you keep on getting into the pancreatic duct repeatedly, and you have to resort to, sometimes you have to resort to putting a wire in the pancreatic duct and then put a stent in there and then attempt a CBD cannulation. In that case, by all means, you leave a stent there. But if it's 1 or 2 or 3 attempts,
There
it's
is
also.
one technique which is called double wire guide technique.
Yeah, well, that's what I'm talking about. Yes, yeah.
CBD cannulation. So is this high risk for pancreatitis also, this technique?
Anything which is unneeded extra is high risk. You are introducing a complication source there. Ideally, you should get into the CBD. You should get into the CBD on the first attempt. That's ideal, but it's not ideal. I think Khalid wants to.
Technique to cannulate CBD. Is this high risk for acute pancreatitis?
We will see. We'll let Khalid speak.
So whenever you think about this procedure, post-ERCP pancreatitis, it's not just like how many attempts you did on the pancreas, how many times you put the wire in there. It's mainly 2 things you have to look at before you make a decision about putting a stent in the pancreas, or start thinking about, is it a high-risk post-ERCP pancreatitis or not. One is the patient factor, and other is the procedure factor. So putting like these things, just saying, oh, I went into the pancreatic duct 3 times, I gotta put a stent in there. Okay, you went into the pancreatic duct 3 times, you put the cannula. Now, to put a stent in there, you have to inject that pancreatic duct, okay? You added an extra risk to that of post-ERCP pancreatitis. Now you have injected, now you have to put a wire in there. You are adding another extra risk to post-ERCP pancreatitis. And the wires you guys use, the wire we have here in Pakistan are mainly 025 or 035 wire. For post-ERCP pancreatitis, that wire is the risk of pancreatitis itself. Okay, because you are going to go into the side branch, you are going to perforate, that's going to cause definite pancreatitis. Now, the stents you have, putting a stent in there, so every time, I agree, you do an extra step to the procedure, you add more risk to post-ERCP pancreatitis. So get this out of your head, that 3 times I went into the pancreas, I gotta put stent in the pancreas, because those 3, you have to add 7 other steps. And now you're making it 10 attempts for no reason. So I always think about this, like when do I need to do, put up a stent in the pancreas? First I will say, what type of patient I got? What are the patient factors which will make it high risk? Okay, it's a female, 30 years old, pancreas looks beautiful, small pancreatic duct, very high risk post-ERCP pancreatitis. Okay, it's a man, 60 years old, pancreatic cancer, forget about post-ERCP pancreatitis. They almost never get it.
No.
Okay, so don't be like this is the first thing, is the patient factor. Then your own factor, the procedure factor. How many times you injected, how many times you went in there, and did you do a pancreatic sphincterotomy? For post-ERCP pancreatitis prevention, you never need a pancreatic sphincterotomy. So don't do that for that reason, because now you are causing a pancreatitis.
Definitely.
Yeah, so it's just so many things come into that, and it's not, and post-ERCP pancreatitis is not your injection only. It's the trauma. It's the molecular genetic factors. So it's just it's so many things which come into that play, that it's a judgment is patient by patient. Don't just read one paper, 3 attempts, this type of pancreatitis, these patients had this amount of pancreatitis, this percentage. It's a combination of factors. So every patient is a different risk with regard to post-ERCP pancreatitis. Okay?
Yes, thank you very much. That was very elegantly put.
Oh, double wire technique. So double wire technique is, the purpose is, it is if you have a hard time getting the wire into the pancreas first, like you are having a hard time getting into the bile duct, the purpose of the double wire is you put a wire into the pancreas because that's where you keep going. And then what that does is it straightens the papilla for you. That's the only thing it really does, and it's an easy access to the bile duct. Double wire technique, wire itself, if it is in a good position, it may be a slight high risk of post-ERCP pancreatitis because you put the wire in there, you already manipulated it. In those cases, I personally will put a stent in there because wire is already in there, everything is in place. The only thing I gotta do is put a small stent in there. So it is a little extra risk, yes, to post-ERCP pancreatitis. I personally, we have every type of wire, we have every type of stent. So I will choose the best, smallest, longest stent, and without any internal flanges. If possible, pigtail stent. That's what I use for post-ERCP pancreatitis because I don't want to put a straight stent and which has the internal flanges and then stents migrates into the pancreas.
I couldn't emphasize the last bit more. I only use single pigtail stents. Yes. I do not use straight stents when trying to prevent pancreatitis because I have seen a nasty migration in a young doctor from another province, and she's now got pancreatitis, chronic pancreatitis because of trying to prevent pancreatitis. Okay, so a straight stent, if you want to put it, make sure flange is not there. So the idea is that stent should not go in. If the pancreatic stent goes in, it's a nightmare to take it out.
We always use
and
pigtail.
One more thing, remember that, like the colon has a watershed area, like a splenic flexure, pancreas also has a watershed area, and that's the neck of the pancreas. So whenever you put a stent in there, either it has to cross the neck or it has to end before that. Okay, so that's where the patients develop strictures. And it also is an angle there. So if the stent is ending right there, with every peristalsis, stents go into the duct, comes out, in, out, that's where they are going to develop the strictures. So just remember that. And if you are, it's an ANSA loop in there and you're trying to prevent a post-ERCP pancreatitis by putting a stent, you actually are causing a lot more damage in there than ERCP was going to cause.
Let me also add here that most centers here I know do not have 5 French stents. And I've seen patients being put in, putting 7 French stents.
Which is too big. Too big.
It's really too big.
And those...
3 French, if it's available, but most centers don't have 3 French. Most centers, in my opinion, don't even have single pigtail 5 French. So if you have, if you're going to put pancreatic stents,
it's better to leave it.
Sure that you have the right stents with you.
And with regard to French, like up 7 French is never should be put in the pancreas for prevention of post-ERCP pancreatitis. Bigger size the stent, bigger diameter, more risk of like ductal damage. So I would either do 3, 4, and very few cases of 5 French because I cannot get through the neck safely, and I would not keep trying to get the wire through that area and cause more damage. In those cases, I will choose a very short stent, 2-3 centimeter stent, but 5 French. If I can get through the neck of the pancreas without any problem, I never put more than 4 French, either 3 or 4 French. Good thing about the 4 French stent is that can go over any wire. 3 French stent only goes over 018 wire or 021 wire, which you guys don't even use.
Yes, that's true. Secondly, can I just stress the fact that if it gets to double wire technique, you shouldn't be doing it. You should get somebody more skilled to do it because he will do it in a less traumatic manner. So try not to box beyond your weight. So if you are a bantamweight boxer, do not fight a heavyweight opponent. Right, post-ERCP chemoprophylaxis for pancreatitis. There's loads of pharmacological agents have been used, most of them unsuccessfully. Whenever you see lots of drugs being used, then you see that there is no ideal treatment for it. However, studies have shown, it's evidence-based, that NSAIDs do help prevent, and most of the studies have been done with diclofenac and indomethacin, and they have both been effective. And we use them routinely in our practice. So all our ERCPs get diclofenac suppository. Again, we mentioned about pancreatic duct stent. The important thing is don't put it in unnecessarily. Don't do unnecessarily pancreatic duct sphincterotomies. Management is like, any acute case of pancreatitis. You have to, whenever you do any procedure, look for complications. Try not to push it under the carpet because somebody else might find it in a worse state and your reputation will be even worse then. So if somebody is complaining of abdominal pain, always post-procedure, always examine them, listen for bowel sounds, check their amylase levels, do CT scans or abdominal x-rays, and check that they have not developed another complication like perforation or pancreatitis. Because the earlier you recognize it, the better their chances are. So nil by mouth, intravenous infusions, analgesia, nasogastric tube if required. We don't put it in routinely. Antibiotics, not routinely, but I think here they may be giving it more regularly, and you get help with CT scanning because CT scanning is one of the best modalities to image the pancreas at that stage. And if they require ITU or HDU care, surgical intervention or radiological. Perforation, the risk is there. Sometimes you see after procedure, you might see air around in the retroperitoneal space, or sometime pneumomediastinum. So most of the time they are self-limiting. They would heal themselves. They do not require any surgical intervention, and the patient would get better after overnight stay or a couple of stays in hospital. It is related to procedure, mainly sphincterotomy or sometimes more commonly in pre-cut, because in pre-cut, your cut is not directed. It is a free cut. So I always discourage people, especially beginners, to even think of doing pre-cuts. The other possible way is you can get a perforation is in the afferent loop in Billrod 2. It's not necessarily caused by the scope itself going through the loop, but by the kinking or by the bend of the scope causing disruption or tear. So if you are attempting build or two, ERCP in build or two patient, always leave it to the experts, because trying to push the scope in would cause a perforation in the loops, one of the loops. Yeah? So always be careful.
What about sphincteroplasty related?
Again, we should not mention sphincteroplasty in this meeting. It is a high-risk procedure. You should not, don't box against a heavyweight boxer if you are a bantamweight. That would be what I would say. So forget about sphincteroplasty. We are not discussing sphincteroplasty. I'm not teaching it. I'm not promoting it. Let's not do sphincteroplasties. Always recognition is important, early recognition. Again, to carry out your sphincterotomy, you must make sure that your cannula is deeply embedded into the CBD. Don't attempt sphincterotomies if you do not have deep cannulation. Some people try to, cut through like that. It should not be done. Secondly, the correct orientation is always important. If you've got a diverticulum close by, be aware of that. Normally, it's not an excuse that cause a perforation because there's a diverticulum nearby. Even if the diverticulum, if your orientation is correct, you shouldn't get a perforation. So always make sure that you got deep cannulation, you got correct orientation of your sphincterotome, so you shouldn't get it. Prompt recognition, early recognition is important, and it's general medical care. Surgery, most of the time you wouldn't need it, but if needed, the surgeon should be involved early rather than late. Right, so you can get pneumomediastinum, and you can see it on the right. Sepsis can occur. It is a definite recognized complication. You can get sepsis because of delayed sepsis from blocked biliary stent, but even post-procedure you can get it. And even after you've done sphincterotomies, in patients who've got open sphincterotomies, they can get recurrent cholangitis as a result of that. Because before you do a sphincterotomy, it's a watertight system, air and watertight. But once you've done the sphincterotomy, it becomes open to the rest of the GI tract. So bacteria can easily ascend into the biliary tree. Bleeding, well, you shouldn't get it. Okay. We are almost coming to you shouldn't get it after diagnostic ERCP, but post-sphincterotomy, one can get bleeding. 1.5, 2 to 5% is the thing. Most of the time, the general ooze will stop without any intervention. Usually, you have bleeding. The main thing to do is do not leave your access. Make sure your guide wire is in while you are carrying out any procedure. After you've cleared the stones, you've put the stent in, by the time you finish with that, your bleeding would have stopped. If it has not, then you can carry out treatment, and that would include either further coagulation with the sphincterotome, or injection of adrenaline, the first thing that we do, or you can use hemoclip, or you can use hemospray, anything that would stop it. If it is massive bleeding, we tend to use fully covered metal-like biliary stents. It causes tamponade and stops the bleeding. More frequent in patients, in certain high-risk patients with coagulopathy, liver disease, cirrhosis, renal failure who are on dialysis, patients who are on anticoagulant and antiplatelet agents. More often in inexperienced operator, pre-cut sphincterotomy, extension sphincterotomy, and use of cutting current as opposed to coagulation current. Ideally, it should be an endocut current or a blended current. So the first thing we do is usually adrenaline spray or injection, coagulation current with the sphincterotome, balloon tamponade sometimes would work, or even the process of taking the stone out, and rarely angiography and embolization. Right. Other issues are cardiovascular and pulmonary issues, especially in patients with COPD. Basket infection is fairly rare but embarrassing complication of ERCP because if you are not judicious about the size of the stone and the type of basket you use, you might get it impacted, and it is very difficult to dislodge at times, and you might end up with the strands of the basket sticking out of the patient's mouth. So try to avoid that. Sometimes you've got these rescue lithotriptal baskets. In case you have your basket gets impacted, you've got rescue lithotriptal, you attach it to that, it cracks the wire of the basket and you can pull it out. Very rarely you would require surgery. Gallstone ileus can be caused by the big gallstone that you've removed and left it in the GI tract. Extremely rare but possible. Contrast allergy is a possible risk of complication. Musculoskeletal injury is possible in positioning, especially if they're lying on the side, they might get a frozen shoulder or nerve damage. Renal dysfunction due to high bilirubin level or dehydration following the procedure if you do not give them enough IV fluids. Distant infection is possible. Always prompt recognition and owning complication. Do not push it under the carpet. Professionalism and communication. If a complication has occurred, inform the patient, inform the family that that has occurred and that you are working on it. Documentation proper is important. Standard of care issues. Always think of was that procedure really needed. Always think of whether that was the right procedure, whether that should have been an EUS would have been better or MRCP would have been better, and post-operative care. We'll stop here. Thank you. Thank you very much for your attention. Any questions? I think we took most of the questions as we went along.
So there's 15 minutes break, and we'll continue at 11:30 with the last lecture of the day, and then we'll be doing a
Model.
demonstration on the
Model.
Okay, so 15 minutes break, 11:30.
I think what we'll do is we'll do
If you
micro
want to sit
teaching.
and discuss,
Yes, you
yeah.
can always do micro teaching sessions. Because rather than just give lectures, it's better to have more interactive sessions.